මේක දාලා තිබ්බත් topic එක තිබ්බත් started දැන්. Right. Right. මේක අර මෙතන වැටෙන්නේ නැහැ මේක. වීඩියෝ වැටෙන්නේ side එකට. Yeah. So good afternoon everyone. I hope that you all are linked through the web for our CME lecture series. Today again we are going to talk about an interesting topic. It's about bariatric surgery. It's not really bariatric surgery anymore. It's called metabolic surgery now. So today we have a speaker who has specialized in that area, who has done his training in New Zealand for 2 years in bariatric surgery. And he has come back, like, you know, he's not a prodigal son, so he has come back. So he's currently serving in KGOL as the consultant surgeon, right? General consultant, general surgeon, but he's doing bariatric surgery. He has done about 60 to 70 bariatric surgeries. He might show some pictures. So all these years he has done wonders to all these females who are on the flabby side to make them like, you know, thin, beautiful ladies. So he has done that. But actually, when we discussed, you know, you realize that it is this surgery, the bypass surgeries and all these surgeries, bariatric surgeries, not considered a bariatric surgery anymore. It's considered as metabolic surgery, because you all know that most of this NCDs like diabetes, hypertension, and hypercholesterolemia, all these things can be reversed by this surgery. So it's picking up in the West, of course, it's picked up, and it goes as a metabolic surgery. Just to give you so if you perform a metabolic surgery in, for example, in a UK hospital, the hospital gets 25,000 US pounds, sterling pounds for that particular surgery. So because it's actually, if you look at it, it's better to kind of get rid of these diabetes and hypertension by doing one surgery than managing them for years and years. So anyway, Dr. Kishanda Bogammana is one of my colleagues and a good friend of mine. He has passed, he's a graduate of Peradeniya. He passed out in 1998. And then he did his MS. He got MS Colombo. And then he did this foreign training in New Zealand for 2 years. And then he came back. He's a very skillful surgeon, not because he's my friend, but I've seen him operating and taking up this challenge of performing this bariatric surgery, metabolic surgery in the periphery without any help is, you know, then it speaks about himself. So I'm, without any much delay, I will let Kishantaka take over the podium. So what do you?
Good morning. Thank you very much for giving this opportunity to me to give this lecture. Especially thank you to KSM Secretary Dr. Arinda Anupala. So anyway, this is a kind of new topic for you, but now is demanding field, not in Sri Lanka, worldwide. So I thought to give some kind of basic principle behind this metabolic surgery. So this is not an easy thing. This is a complex and complicated topic. So anyway, I'll try my best to explain what I can do for you. At the end, we'll see whether you are interested or not. So anyway, at the moment, as Dr. Arinda said, I'm a general surgeon at KGOL Hospital. So we'll discuss some slide, what is the role of surgery to get rid of these metabolic diseases. So when I was in Trincomalee Hospital, actually, I will start with an example. So one lady, one female patient, 32 years, come to my surgical clinic. She's a housewife, married for 10 years, but she doesn't have any children. So actually she's morbid obese, BMI 48, body weight 113, and height 154 centimeter. So not only she's obese, she has some health issues. Basically, we divided into 3 sections, metabolic issues, so health issues. One physical problem, as you know, because of obesity, and another is a metabolic problem, metabolic diseases, and third one is psychological issues. So actually she is a diabetic patient, type 2 diabetic for 5 years on 2 medication, metformin and glycosides, and also hypertension for 3 years on 2 drugs. Dyslipidemia for 2 years on treatment. So all diabetic, high blood pressure, dyslipidemia, everything under good control. So then main problem is her subfertility for 10 years. She has been married for 10 years. She has done almost all investigation. She has gone to so many hospitals, not only hospital, you know, Devala, there are a lot of Devala in Trincomalee. She has gone behind God to have a child. Still, she's not lucky to have a child. So we'll see what we can do for her that also. And another metabolic problem is, as you know, the fatty liver. We did ultrasound scan. She's having our grade 2 fatty liver and abnormal liver function as well. So there are some physical snoring. She's difficult to sleep. She's struggling with sleeping all night because snoring and a little bit sleep apnea as well. Chronic backache, knee pain, and then because of that, day-to-day activities. So she's struggling with this problem. The main issue, another issue is psychological. She has the suffered problem as well as obesity. You don't believe she hasn't, you know, she is not going out. At that time, she hasn't got to the market. What she does actually, she gives her sizes and all of the clothes. The husband is the one who goes to the market and buy all things to come home. It's like that. She doesn't go to the society because of, you know, our culture. The mother-in-law and the husband relatives, so many problems because of no children and obesity, difficult to do work at home, day-to-day things. So then because of that, what we can do for her? As you know now, she's on medical treatment under good control. So she has tried so many things to lose weight, especially diet. You don't believe, actually she doesn't eat. She does eat just 2-3 pieces of vegetable for her dinner. Still, she could only lose about 10-15 kilos. She has done all more exercises, but main problem for her this because of the weight. She can't do any regular exercises like jogging. So she made her main hobby actually. She liked to do cycling, but still because of this weight, she can't do this one. And we advised to why don't you go and swim? You know, she's living just close to the beach or sea. But our culture, you know, ladies, they don't go and swim in the sea to lose weight. So even she doesn't go to the town. So then we thought some kind of surgical option, surgical procedure to cure this problem. So it might be a permanent solution. Otherwise, she's struggling with life. So that's then this topic is comes at this point. Like we call metabolic surgery. Usually, I know in the 18 and 90s, pediatric surgery, obesity surgery, and weight reduction surgery. That is now it has changed. Actually, I'll explain why it has changed to metabolic surgery. So we didn't have a good, lot of consultant there. Fortunately, Dr. Arinda Dharmapala with me, my surgeon. So he also interested about this metabolic surgery and pediatric surgery. So I discussed with him about this lady, then consult anesthetist and psychiatrist, all be happy, and we thought to do some kind of operation to do something for this lady. So then we explain all the consequences and all the benefits and all the things to her. She's happy, her husband is happy. So then we did an open surgery, midline laparotomy, and post-operatively we keep her in the ICU for the better observation. The main problem, as you know, is the DVT, pneumonia, and the pain. So under epidural cover for the post-op pain, she was doing that very well. So next challenge was actually the control of diabetic. As you know, we do have a sliding scale, so in the ward, but here we do have a specific sliding scale, not like routine scale, because we start from 2 units of insulin to maximum 10. Post-operative, this kind of patient are very, very sensitive to insulin. So according to blood sugar level, we start 2 units of insulin, maximum go to 10 units. If you do normal routine insulin doses, so if you follow the normal sliding scale, she might end up with severe hypoglycemia. So this is special kind of scale, and according to that, we did manage her diabetic part. Fortunately, post-op blood pressure normal, we didn't start any drugs. Then diet gradually, first the ice cubes, then water, 30 cc, 60, 90 cc per hour, like gradually, then free fluid, then normal solid diet. So then at day 7, actually, we discharge the patient on day 7. So what do you think? What will expect? Now we have done this surgery to lose weight and to get rid of this metabolic obesity associated metabolic diseases. So what do you expect at day 7? Obviously, you know, she hasn't lost any weight, because even though keep fasting for a few days, maybe 1 or 2 kilos she has lost, but almost her body weight is normal. But blood sugar almost normal. At day 7, she hasn't lost any weight. Okay, blood sugar completely normal. She was on 2 drugs, metformin and glycoside, and for five years. Then blood pressure pretty good, normal. Then body weight, as I said, almost normal. So then she went home after 7 days without any medication for her metabolic issues. Even we haven't started anti-cholesterol tablet for her dyslipidemia. So she went home without any medication apart from paracetamol for her pain. So she's very happy. So then at 3 months, we review her. So she has lost about 15 kilos. Now 3 months gone, still blood sugar normal, blood pressure normal, and lipid, we did the cholesterol, almost normal without any drugs. So then at 6 months, still no diabetic, blood sugar normal, blood pressure normal, lipid normal. She has lost 25 kilos. Now she's 88 kilos, was 113, 113 kilos. She has lost 25 kilos. So no more snoring. The husband also came with her. He's the one happiest man in the world, like pig in the mud, you know, because he's the one who's suffering from this snoring because she couldn't sleep because of snoring. Now he said, I'm very happy because I can sleep. So no more snoring. Psychologically so happy. Okay. So then 1 year, obesity related all metabolic disease, dyslipidemia and diabetic, high blood pressure, all gone. So we did ultrasound scan at 1 year. She had grade 2 fatty liver with abnormal liver function. Then after 1 year, almost liver normal, ultrasonically, and biochemically also liver function has become normal. So this is just 1 year. She has lost 25, then 35. Gradually, she's losing her weight. So at 18 months later, still I can remember when I was, that means 1.5 years after the operation, when I was, you know, going to this other clinic complex, a lot of people there, 100, 200 people waiting for the clinics. Suddenly I heard doctor, when I just turned back, I saw this lady. She just came and actually went to worship me, and she said, Sir, Hindamada, Lame Kambinani. Oh my God, all the people around the clinic, people are staring at me. I don't know what to do. She was just, when they're like, you are Sir Hindamada, Lame Kambinani. So I just come. We'll come to my clinic. Then I took her to my clinic and asked, actually 6 months pregnant. You see now, she has been almost for diabetic 5 years, hypertension, dyslipidemia, fatty liver, snoring, and subfertility for 10 years. It's almost all investigation done. So just now, after 1 year, 1.5 years, she has become pregnant, almost 6 months now. So I'll show a little bit. This is a picture actually just in front of the clinic I took. So then I'll go behind. I try to explain the basic principle. What is this metabolic surgery? There are 3 types of metabolic surgery. One is restrictive, where you limit the food intake. Then malabsorptive, where you can eat as normal people, but absorption is be reduced. So, and there are some surgery combine both restrictive and malabsorptive. So restrictive, you know, there are so many surgeries. Surgeons, they do a lot of type of surgeries as metabolic surgery worldwide, but I'll explain the famous, you know, popular one. One is lap band. This is a very famous operation in Australia. Then sleeve gastrectomy. Malabsorption at the moment I don't want to discuss because routinely we don't do malabsorption. We used to do in 18 and 19s because of a lot of complications and bad consequences. A lot of people, they don't do malabsorptive pure, but combined is a gastric bypass is the popular operation or gold standard operation. Either we can do open or laparoscopically. This is a lap band actually. I'll go through briefly. So where we put a ring, actually bilateral ring, okay, band around the stomach just below the gastroesophageal junction. Okay, this band is expansible. That means there's a tube which connect the band and the port. Port is we place under the skin where you can inject water or normal saline. Then you can expand the band. That's what we call adjustable, laparoscopic adjustable band. As example, if you want to go to the wedding, just you release the water, go and eat what you want. Okay, so enjoy the wedding, enjoy the dinner or meal, then come home, then you can inject normal saline or water to the port which under the skin, which is placed under the skin, then constrict this one. So you can eat more. So this is a very, very popular operation in Australia. So then another one is sleeve gastrectomy. This is a very simple operation to the patient as well as to the surgeon. A lot of centers, they do laparoscopically, which was very easy. There's no rearrangement of intestine or anything, no foreign bodies or anything. Just you cut the stomach along the lesser curvature to make a small pouch. This pouch might be something like 15 milliliter or 20 milliliter, something like that. So here we restrict the intake. So this gastric bypass is a little bit complex procedure, but it's considered as gold standard worldwide. So here what we do, you make a small pouch along the lesser curvature of the stomach. It's like my ring finger, something like that, 10 milliliter capacity. Then rearrange the small intestine as you know the what we call root NY. So as shown in the picture, we bypass the duodenum part. When you eat something, it goes through this esophagus, small pouch, that will new pouch of the stomach, and then to the jejunum. So then all the stomach secretion, pancreatic and biliary secretion meets food at below about 10-20 centimeter down the jejunum. So little bit malabsorption part as well. That's why we call this is a combined both restrictive as well as malabsorptive. So there are indications to this kind of metabolic surgery. As you know, BMI, the international BMI, as well as there are WHO has given BMI chart to the Asia Pacific region, but still we do follow this BMI 40, more than 40, or the BMI 35 plus one of obesity associated metabolic disease like diabetic, high blood pressure, cholesterol, suffered, something like that. So that these three, if the patient is more than 40 BMI, yes, she's good candidate have metabolic surgery, or the BMI more than 35. So for your interest, I have morbid obesity is considered 37 in our region, or indication the second indication 32 plus one of obesity associated metabolic disease. So you know the BMI is actual body weight in kilos. Then you have divide height into height in meters. So and also you should know what is ideal body weight. Ideal body weight, there is a chart for your height, this weight, something like that. If you are 100 centimeter, then your weight should be like that. So the patient might ask, after the operation, what will happen to my body weight? It slowly, gradually, it might go to the zero. No. So we can't achieve ideal body weight. That's the most important thing. You know, by doing this kind of surgery, we can't achieve ideal body weight. But there are some people, some patients I have seen and recorded, they have achieved ideal body weight, not only because of surgery alone, they do a lot of exercises and all the other things. So then what the expectation is to achieve, the excess body weight is you reduce, you calculate the ideal body weight, then the actual body weight, then the gap between the ideal body weight and the excess actual body weight called excess body weight. That kilogram is excess for that patient. So we achieve our target to achieve two-thirds of the excess body weight. When you go through the articles, these words come. That's why I am trying to explain what is this excess body weight. So our target is to achieve 2/3 of the excess body weight. Usually we expect 2 to 2.5 kilos per week after operation. So now we will see what are the effects of metabolic diseases. So generally this is going on, from started 1967 first gastric bypass. So initially what they did, this surgery only for weight reduction. They didn't do for patient with diabetic, high blood pressure, ischemic heart disease because of the post-operative complication. But slowly they have realized by doing this operation, we can have a solution for metabolic disease as well. So resolution of diabetic. Okay, if you go to research article, review articles, 80 to 90%. And there are some patients, we know, and there are patients, we can see some improvement. That means it's 100%. If patients on insulin, after the operation, might need 1 or 2 drugs or small dose, like an example, this patient, almost blood sugar normal, we didn't start anything. Some patient might need metformin 250 milligram twice daily, something like that, for 1 year, 1.5 years. But what happens is after the weight reduction complete, the blood sugar will improve further. So then all around the scientists, they try to find out what is the secret behind operation, day 7, blood sugar gone, blood pressure gone, everything. Okay, what is the secret behind this phenomenon? So there is a lot of researchers. Okay, so we all know once you lose weight, we know diabetic, blood pressure, fatty liver, everything will disappear. But this is after 7 days, still hasn't lost even single kilo. So then they have done a lot of research. Actually, what they found, that we do have a insulin resistance in our body. So people, they measure insulin level in patient's body in serum preoperatively, then at day 7. So they have seen dramatically reduction of insulin level of these patients. Insulin level. So what happens is, in pancreas is producing enough insulin, but at cellular level there is some problem. There is a problem to intake of this insulin or glucose. So after gastric bypass, we have seen reduction of serum insulin to normal level. So then peripheral tissues or cells, they can uptake into blood sugar, glucose level. So they thought some kind of factor which should be secreted by the duodenum, because I'm talking about gastric bypass mainly. So gastric bypass, when you do gastric bypass, we bypass part of the duodenum. So then food doesn't touch duodenum mucosa. Duodenum doesn't see any food. Then they thought some kind of factor, they call factor X, should be released by the duodenum after this operation. So then there are a lot of researchers going on, and actually we did a lot of researchers. We thought, okay, this all the food absorption, GI blood going to the portal vein, as you know. So then what we did actually, at the time of surgery, the falciform ligament just obliterated our umbilical thing. So we dilate the falciform ligament and we put a 3-way catheter along the falciform ligament. It goes to the portal vein. So we took blood, 150 milliliter of blood at the time of surgery. Then we did the surgery, closed the abdomen. We didn't remove the CV line, which is in the portal vein. We take it out. At day 7, we took another blood sample. Like that, we did have about 500 blood samples from 500 patients. So then the scientists, they analyzed, they found actually there are about 5 different type of protein. Okay, which wasn't there in the pre-op, but it's there in the post-op blood, in the portal vein. So like that, then we did research on obese rat. We did a gastric bypass to the obese rat, and we take all the tissues and what is going on. Still the people, scientists are struggling and go behind these researchers, but they couldn't find a good answer for this phenomenon. So another is, so you might ask, why some patient we can't cure diabetic, just only improvement. Usually we do have formula. If obese patient with diabetic for more than 10 years, okay, there's a less chance to cure or resolve. Or if someone on insulin, okay, there's a less chance. But we know 100% improvement there. She might, or patient, he might end up with to metformin 1 tablet daily, something like that. But there is a less chance to resolve or cure. So if you go to the PubMed, there are so many articles. I have some. So then high blood pressure, same resolution 89%. Then again, we can cure hypertension, and we can expect 100% improvement almost all patients. Then dyslipidemia, same thing, resolution 80% and improvement almost 90%, 90-100%. Then I'll discuss the subfertility or other problem with this obese people. They do have polycystic ovarian syndrome. So as you know, we gynecologists, they prescribe metformin. They know this subfertility and PCOS patient they have analyzed, they do have high insulin level in their blood. They know that insulin resistant word. So they start metformin. Maybe you have seen a lot of subfertility or polycystic ovarian syndrome patient on metformin to get rid of this insulin resistance. But we know here, after gastric bypass, insulin resistance disappear after 7 days. So then, what is the then patient might ask, okay, now I'm happy to do gastric bypass. I won't have a child. When do you have my first child? What do you think? How long does it take to become fertile after this operation? You don't believe they become fertile immediately after within few days. That means immediately they can have a child. But we always say better to wait 1 year to complete your weight loss. Okay, and we'll assess your vitamin level, everything. Then you become pregnant. Usually we say at least you have to wait 1 year if you really want a baby. So I can remember in New Zealand actually, the patient discharged with some kind of contraceptive method immediately. Day 7. We always advise use some kind of contraceptive thing because you will become pregnant, conceive. So there has been, this lady actually has been investigated for almost 10 years. She didn't have a child. Now she's very happy. She does have a child. So another main problem with obesity is sleep apnea, obstructive sleep apnea. So a lot of people, but they do use this kind of machine, CPAP machine to sleep. Otherwise, they can't lie down in the bed during night because this obstructive sleep apnea. So sometimes some people, they spend the whole night in the chair, that's a sitting position, to get rid of this sleep problem, apnea problem. So look at the quality of life. If you have to sleep this kind of with this machine, what about your quality of life? So this operation, this gastric bypass, is a fantastic solution patient sleep apnea. I have operated actually 4 or 5 patients. All the patient has been referred by chest physician on CPAP machines. They comes to the ward, they come to the theater with the CPAP machines. Okay, but after 2-3 days, they say, I am happy. Okay, after 2-3 days, they say, I don't need machine. I can sleep well. Still, we don't know the mechanism, but we believe some kind of edema might be the reason to sleep apnea. So after gastric bypass, after 2-3 days, they get rid of this excess water in our tissues, might be the reason, the immediate improvement of sleep apnea. So actually, if you go to the PubMed, there are so many articles, gastric bypass versus sleep apnea. You can, so good results with good satisfaction of the patients. So other main problem now everywhere, not in adult, even including children, the fatty liver or non-alcoholic fatty liver, or the NASH, non-alcoholic steatohepatitis. This is the one in future leading cause of end-stage liver disease, not only in the other countries, but in Sri Lanka as well. So as you know, we always advise to lose weight, control your diet, okay? Then yes, there's a lot of patients, they do like that. So, but here, morbid obese, they can't do proper exercises. Now already they on limited diet, still they do have this fatty liver, grade 1 or 2, end up with the end-stage liver disease. But we know the risk after gastric bypass, 100%. Almost all the patients with fatty liver, they, okay, with time, liver become normal. What we did actually there, we do liver biopsy at the time of surgery. Then after 1 year, 1.5 years, we repeated the liver biopsy. So initially, first biopsy, severe steatohepatitis with sometimes fibrosis, but after 1 year, almost normal liver. So this is the, I think, one and only solution for patient with fatty liver and obesity. So what about the cirrhosis now? If you do this gastric biopsy to a patient with chronic liver cell disease or cirrhosis, what will happen? As we all know, cirrhosis is an irreversible process. All the liver parenchyma are replaced by the fibrosis, isn't it? It's not, we can't reverse it. But I will say we had 4 patients, okay, full-born cirrhotic liver at the time of gastric bypass. We did biopsy, okay, with severe abnormal liver enzyme as well. So after 1 year, we did repeat liver biopsy. And usually we do have a pathologist, and we do have a conference once a month. So pathologists won't believe the results. So they say there's a significant improvement on the liver architecture, liver parenchyma. They have seen disappearance of fibrosis. This is for the full-born cirrhotic liver. So still we don't know the reason. But scientists, they don't read it, but we have noticed, we have observed the results. So generally, after gastric bypass, the quality of life, you see, no snoring, you can do what you want. I can remember one patient, her main hobby was, he won't ride a horse. How can a horse be this kind of lady? So after gastric bypass, when I was in doing the foreign training, so this after gastric bypass, after 1 year, she came and, she told, I'm very happy I can do then my, my things. Like this lady, she wanted to ride cycle, but she couldn't. Now she happy and she ride bicycles and go to the town, go to the market, buy what she want and everything. And a lot of research they have seen the increase the life expectancy as well. So as you know, this is a major operation, either laparoscopically or open. So there are a lot of complications. The commonest one is deep vein thrombosis and pneumonia. So we have to manage. The other important thing is the pain. We have to manage pain, then we can mobilize. So we need specialized centers for this kind of operation actually. So always we explain with the patients, these are the problem, these are the consequences. You have to sacrifice to some extent to achieve if you want to have good quality of life. A lot of people actually, they say, no, I'm happy, do this for me. So we know definitely they lose weight, they get rid of this diabetic, high blood pressure, but only problem is diet. Because this small new pouch, gastric bypass, new pouch about this size, 10 milliliter, they can eat only 1 or 2 tablespoons, okay, per meal, morning, lunch, and the dinner, 2 or 3 spoons. And they are happy because they say, already we have our meals like that. We don't eat much. Another main issue is, okay, if she does eat 100 types, varieties of food, chicken, then fruits, whatever things, after the operation, and we can't say, now you can't eat these things, you can eat these things. Very unpredictable from patient to patient. Generally, they can eat 80. Initially, 100 varieties. Now they can eat 80. 20, the body doesn't like. Here mainly what I have seen actually the rice. But otherwise they are happy with 80 types of varieties food. But that we advise, if you can't eat rice, the boy, there are so many types of rice, you know, say tambabuhal, kida, kekuluhal, you know. So try different ways. So if you can't bread, then you can eat sliced bread, something like that, roast pan or something like that. So she will be her teacher in next 3 months. We always say, you eat something. If the body doesn't accept, okay, you don't eat. Try in another way. But almost all the people who had this gastric bypass, they're happy with meal. Okay, amount is less and less variety. So other problem is always patient has to take a multivitamin tablet religiously for rest of her life, multivitamin tablet, because patient might end up with micronutrient problems. Always one multivitamin tablet per day rest of her life. Then about other problems, iron, folic acid, and B12. What we have seen about 10% of people, they do develop iron deficiency. Another 10% folic acid, another 10% B12. Altogether, about 5% people, they do develop all three. So after 8 months or 9 months, we check their iron level, folic acid, and B12. If at that time, if they are okay, if the normal and all, the patient doesn't need any supplement. But according to the level, we have to prescribe iron, folic acid, or B12. And the controversy about vitamin D, we did a lot of research actually in New Zealand. Even though they don't have much sunlight, the patients, they are okay with vitamin D. But in other Europe country people, they start vitamin D. So I think in our people, we don't start vitamin D because we do have enough good sunlight. So what about Sri Lanka? You might think, oh, we don't have much problem of obesity, fatty liver, or other metabolic disease like diabetic, lipid, hypertension. I'm telling now, just you go to the PubMed, there are a lot of Sri Lankan doctors, they have done a lot of researches and studies about fatty liver, not only in adult, also in school children. Okay, and in a lot of societies, diabetic, hypertension, and obesity, and with the metabolic syndrome, it is now becoming a huge problem to our country. So I haven't got any of these articles, but if there is freely available, go to PubMed, you can see some figures. So I think because of that, we have to take that challenge, and we have to introduce the metabolic surgery to our people. So in my experience, I am not a big guy, but I have done about 65 patients so far, age between 18 to 55, BMI range in 40 to 60, and diabetic 52 patients. Okay, all patients less than 10 years. So as we expected, resolution 100%. Then high blood pressure, 44 patients. Out of that, 39 normal blood pressure. 5 patients, significant improvement, taking 1 or 2 drugs, that's all. And sleep apnea, as I said, referred from physician, had 5 patients on CPAP machines, all gone, all went home without a machine. 1 patient actually donated her machine to the hospital. So she said, after just 7 days, I didn't want this one, so I will go home without the machines. Then she left the machines to the hospital. So we had 5 patients with fertility. So all end up with uncomplicated pregnancies and deliveries. So they're happy now. So this is my experience. So actually, I have seen now a lot of centers so interested about this field, especially Candy and Peradeni are in there. So best thing is we are like gypsies, you know. I'm like gypsies. I'm general surgeon. I'm going to one center, some follow na routine, go something like that. But if we have a best permanent team, anesthesiologist, consultant, nutrition, all together, so we can do a good job to Sri Lanka. So actually, the Candy Chaturanga is very interested, so he's happy to. I think he's going to start. That's very nice to hear. So it's like that. So I'll send some pictures where this makes morbidity too. Actually, apart from the wound infection, I didn't see big other come like DVT and pneumonia. But I had two death, two mortal, two people died. One patient died, 150 kilos, one lady, after 2 weeks. Actually, she had a leak from the anastomosis. So we did reoperate, but she died after 2 weeks. Another patient, actually, 170 kilos man, we did gastric bypass. She lost about 40 kilos. After 3 months, she developed tracheal stenosis. So we did a tracheostomy and transferred. Then he okay with tracheostomy. Then I discussed with the Valisara thoracic surgeons, Dr. Varun. He happy to take over. Then we transferred the patient to Valisara. Unfortunately, this patient has fallen from the bed and dislodged this tracheostomy and died after 3 months. Okay, but see, he said, I'm very happy because I haven't enjoyed my life during the whole life. Just last 3 months, okay, I was very happy, something like that. Actually, unfortunately, he died. So this is one of our patient, one lady. She's with the one Popular Star. So 120 kilos, high blood pressure, lipid, fatty liver. So we did discuss and we offered surgery. She did the surgery. So this is one photo actually about, I can remember 1 year, something like that. Then she came and met me at my clinic. So almost 1.5 years after that. So you can see the difference, 120 kilos, end up with the 65, it was 60, 65. So even if I, so this imagine some people, they don't believe, they say different patients. This is the first before operation. This third one is after the operation. And this is school teacher. She also 110 kilos, has dyslipidemia, fatty liver. So these patients actually, they send pictures after 3 months, 6 months, after 1 year to me. Since I have collected some pictures, so happy end of the 1 year. She now is doing all her athletics and PT. This lady is 23 years old. She didn't have actually any metabolic diseases. She was 96 kilos, but BMI almost 41, short stature. So she has, she's can be 30. You can see the 90 kilos picture, then 76 kilos. Actually, this girl is not working in abroad. When she come to Sri Lanka for holiday for 3 months, her mother told me she didn't go out. She doesn't go out because of her weight. She said, when I am in there, OCS, all the people like me, all are big bodies. So I am not all. But once come to Sri Lanka, I can't go out. Psychology is so depressed. Even she had 5-6 times faintness attack because she want to lose weight, so she doesn't take proper meal. So until 23 years, very young. So I told these are the complications. Mother and I accepted all the things. Then we did the surgery. So this is a slowly reduction of weight pictures, and this is ultimately after 1.5 years. So actually, she has actual ideal body weight for her because she goes to the gym and all things. And this she came to my clinic. It's a picture with me. So this is a very fantastic operation, not only for weight reduction, to get rid of this all metabolic diseases. Actually, this time has come to Sri Lanka, to start this metabolic surgery, to popularize this surgery. So that's all I want to tell. I think you happy. Thank you.
There are questions here. So we don't have audience, so we can't entertain questions. But now there I see some registrars. Are you all have any questions to ask? Yeah.
After the patient assessment, how do you decide what kind of bariatric surgery that the particular patient needs?
That is very typical. The answer is, it's all if you go through all the kind of surgeries like sleeve, gastric bypass, or the lap band, It's very complicated. What I say, if the patient is young, without any metabolic disease, better do sleeve gastrectomy. Very simple procedure, really easy to do laparoscopically. So simple. But if someone with morbid obesity and a lot of comorbidities, so I offer gastric bypass. You can understand. But sleeve also good for metabolic, we don't see immediate effects. But once you lose weight, yes, we know the blood sugar, everything will disappear. But the gold standard for metabolic disease is a gastric bypass. The patient is young, doesn't have any problem. So best thing is to sleeve. They say with time, sleeve, the pouch will become, like a balloon will dilate in 5 years, 10 years. We don't have a long-term data like gastric bypass. But gastric bypass, where I work actually, the professor under Professor Stubbs, he has done almost 1,200 and 15, 20 years experience. So he said, problem with sleeve, with time it might dilate. So patient can eat more, weight regain. So other surgeon, they say, okay, if it is dilate, we go and do the gastric bypass after 10 or 15 years. Because of the young patient without comorbidities, best thing is sleep. Then otherwise go for the gastric one. Actually, lap band of Australia did a lot of lap bands. Now they are failing. Yeah. Now they are all converting to gastric bypass again. No idea.
Yeah.
Ruin my.
Sometimes they do a bridging thing called, it's so obese, like 170. So then you can do a sleeve, which is easier, get a certain amount of weight reduction, and then go for gastric bypass. There are switcher. Those days they used to do the switch. Now they don't do it.
Yeah.
Only in Brazil they do.
Hepatobiliary switch and hepatobiliary diversion. Actually, sleeve they did as a first stage. Severe obese patient, they did the sleeve. Once they lose weight, they did the gastric bypass. Now it has become popular as a
gastric bypass. Yeah. Now thing is, a lot of gastric bypass are laparoscopical. So that is those days we just open. Now people are. So because of that, gastric they straight away go for gastric bypass. Because still they do it laparoscopy.
Sorry? I haven't seen in Sri Lanka. I was just.
It went out of lap banding is going out of it. Slip, it's very problematic. Sometimes it slips and then they come with in the night.
They put a balloon into the stomach, Actually, that's good for the very super obese people. So for 3 months, 6 months, then they might lose to some extent, then go for the other kind of bariatric surgery. Yeah.
So in the absence of any more, we don't have any audience. So in the absence of any more questions.
Oh, Arinder?
Yeah.
Can I disturb you? Dr. Nias here.
Yes, sir.
Oh, wow. Congratulations. It was fantastic lecture. Unfortunately, I could not attend the full lecture. I was busy with another schedule as well. Anyway, thank you very much. And I presume and hope this process will be continued and everybody will take up. And I'm sure the lot of help will be taken from you as well. Thank you very much for this excellent presentation and superb lecture and timely one. Thank you very much.
Thank you, sir. Thank you.
So, right. So, I mean, it's gastric general surgeons also can do it. It's just a bypass. Only thing is taking it up is a challenge. So that is why, even the young surgeons, when you pass out, it can be one of your things that you can perform. But now, the problem is when you say bariatric surgery, the government doesn't allow bariatric surgeries and cosmetic surgeries in the government sector. It's a rule. So because of that, now it goes as a metabolic surgery. So if you say metabolic surgery, I think you can perform. And it's a surgery that you must learn and practice by every general surgeon. As long as you have some experience, I think you can do it. And now Boga has done it as a peripheral surgeon. He has done it. He's first one in Trinco, and then Polonnaru. And so with normal general surgical equipment, we can do it. Only thing is we need to have a good nutritionist, a psychiatrist support, and then you need some expertise in that area. If complication happens, what to do and all that, and then expected weight reduction, and sometimes they lose weight drastically, more than what you expect. If your bypass loop is long, then they start losing weight. So there are things like that where you have to do revisions. So because of that, you need some at least 3-4 months of some fellowship there, but you can take it up. I think all the young surgeons, because obesity, as he said, is one of the commonest. And in Sri Lanka now, NF, like non-alcoholic steatohepatitis, is the the cause for cirrhosis, not the alcohol. The leading cause is that NASH. So it's one of the things that we have to do. So anyway, thank you very much, Dr. Bogammana, for coming and giving us, enlightening us on this field of metabolic surgery, which is, I think, it's not new to the world, but it's new to Sri Lanka. And very few people do it. I think you do it. Then Tejan in Colombo does it. But very few other people take it up because it's a challenging thing, because operating a obese patient itself is a challenge. Like getting him across to the table sometimes is a problem. So anyway, thank you very much for sharing your knowledge with us. And then I like to call Professor Ruwan Jayasinghe to give away the token of appreciation, the certificate. Professor Ruwan, please. Right, so that concludes our CME lecture for this Wednesday. So hopefully next Wednesday also, I urge everybody to present, at least come to the auditorium. We can at least occupy about 25 to 30 seats. So I would like to see some faces, and I hope that everybody will join us through the web. Thank you very much.